really exciting program today. It's a forum on healthcare for all and the best way to get there. It's a debate between primarily the two main speakers. Both would like to get there, but they have different thoughts in terms of how to get there, whether Medicare for all or a different type of plan for how to get there. And it's really, unfortunately, fortuitous that they're having this forum. I think President Trump decided he wanted to maximize the turnout by announcing that he's going to, propose the abolition of the ACA in its entirety, and then just poof, the magic dragon will, I guess, come up with another plan the next day. So I guess we need to thank him for helping to put the danger to healthcare on the agenda for our forum today. Just a few things. The agenda of the speakers is here on this, so you sort of have some idea what the outline is of the plan for the day. I'm Arlene Zaremka. I'm one of the co-founders of Momentum for All, along with a number of other people who are here in the audience. We formed that in December of 2016 as a resistance organization after the Trump election. We are nonpartisan, which means we don't endorse candidates, but we obviously are resisting and opposing the bulk of the Republican and Trump agenda. We have out there what we stand for. The very first item we have on what we stand for is healthcare for all, but we have many other areas of interest that we also work on. We are grassroots. We're all volunteer at the present. There are no dues, so you can join Momentum simply by signing up. And there's sign-up sheets that you filled out when you came in. Missouri Healthcare for All is going to be sharing those with us. We'll send you an email, and if you want to be added to the Momentum email list, you'll just let us know. And if you say, no, I don't want to be added, then we won't add you. Also, if you ever do subscribe to Momentum, and you later decide that you no longer want to get the Momentum emails, you just can do unsubscribe at the bottom of the Momentum email. We currently have about $400 members. Yeah, each member's worth $1. We send out weekly action alerts to all members by email, and some of those are forwarded by other organizations to their members, so it actually has more of a reach than simply the people that are on our list. We have monthly meetings, usually here at the Central Reform Congregation, which has been extremely supportive and generous in offering CRC for our monthly meetings. And we're organized around affinity groups, so the Healthcare Affinity Group is a group that organizes this forum. But we have other groups like on environment, immigration, etc. And we will, of course, also have participated in demonstrations, done lobbying in senators' offices, phone calling. We organized at Diane to educate the people about healthcare issues in 2016. And we are also registered with the Indivisible Action Network, which is a nationwide group that sort of kicked off this resistance connection between groups all over the country. And we have a Facebook page. Representative Cora Faith Walker, the Democratic representative from Missouri's 74th District, House District, will start the forum by talking about healthcare issues in the Missouri State Legislature, and she will moderate the forum. So, without further ado, also want to mention if anyone wants a Momentum button, you can just ask us for one, and they're free. But without further ado, I'll turn this over to Representative Cora Faith Walker.
I am going to try to project my voice, but you all let me know if you can't hear me. I do apologize for being a little hoarse. I've been in Jefferson City screaming at people, if nothing else in my mind at least, and so it's really manifested itself in a really interesting way. So I thank you all so much for having me here. I love the opportunity to talk about healthcare and health policy especially, and so having a captive audience is something that I am really excited about. It's been a pretty busy week for health policy, both in the state of Missouri and in the country. And it's actually kind of funny, but I'm going to maybe talk and speak a little bit in reverse chronological order about some of the things that have been happening this week. And spoiler alert, I'm going to end with a discussion about the Trump administration's announcement last Monday about their plans or lack thereof for Obamacare. One of the things that So just to give you a little bit of more information about me and a little bit about my background, I am a healthcare attorney, and I also have a master's in public health. Prior to running for office, I taught at St. Louis School, University of Law, in their health law program, a class on grassroots advocacy and legislative advocacy specifically related to healthcare issues. And prior to that, I was on the policy team at the Missouri Foundation for Health. And so I have done a lot of work around health policy and health advocacy here in the state of Missouri. This year, I was named ranking member, so the ranking Democrat on the Health and Mental Health Policy Committee in the House. And I also sit on the subcommittee or the Appropriations Committee in the budget for Health and Senior Services and the Department of Social Services, which accounts for about $11 billion of our state budget, or about 1/3 of our entire state budget that deals with health care and Medicaid primarily. And so this past Thursday in the House, the Missouri House of Representatives passed our state budget for the year. Notably absent, or maybe not absent, notably included in the state budget, and was something that we were unable to do as successfully as Democrats, was argue for the removal of language that prohibits Medicaid expansion in the state of Missouri. They put language in the budget that prohibits Medicaid expansion in Missouri. And I was sharing with Ed earlier before the panel began, that in my experience before becoming elected, I really did talk about and I think really understood what I called, and I think a lot of you all would call the moral imperative for expanding Medicaid, the importance of making sure that more than 300,000 people in the state of Missouri can get access to quality, affordable health care. But being on budget this year and being in the subcommittee for appropriations for House Bills 10 and 11, which is Health and Senior Services, Mental Health and Social Services, I really began to get a clearer understanding of the fiscal imperative of expanding Medicaid here in the state of Missouri. Like I said, the Medicaid program, and specifically House Bills 10 and 11, comprise about $11 billion of our state budget, with a big portion of that going to Medicaid as it stands. And yet, there's still a lot of gaps in coverage and a lot of holes for people who don't necessarily have access to health care. Not to mention, there's been some pretty alarming sorts of trends in people who have been getting removed from the Medicaid rolls recently, most notably children who have been getting kicked off of Medicaid over the past year. Missouri has outpaced all other states, it's my understanding, over the past year in the number of children that have been removed from Medicaid. And so that's something that has been really alarming and troubling. But the other thing that was kind of really interesting to me that I discovered in the 1,100-page request from the Department of Social Services, which pretty much handles and administers the Medicaid program in the state of Missouri, is that we're giving a lot of money away to organizations like managed care organizations. The Medicaid managed care line is about $1.3 billion out of the Medicaid budget. And there's a lot of questions and a lot of things that we don't really know about the effectiveness of moving Medicaid to managed care from a fee-for-service sort of a model. Additionally, I was I'm very proud of being able to successfully advocate for increased funding for community health workers. So these are workers primarily that work, well, obviously in the community, but in primary care settings to make sure that individuals are, getting to doctor's visits on time before they have to go to ERs. I've heard stories of one elderly gentleman in Springfield, I think, who kept showing up in the ER with falls, and a community health worker just ended up going to the gentleman's house to install a bar in the bathtub. Just kind of doing these sorts of common sense sorts of things to help avoid expensive hospitalizations. And so during my budget process and during the appropriations process, I was able to really argue to both the vice chair of budget, who's also the chair of the appropriations subcommittee that I sit on, and the chair of the budget committee as well, about the importance of community health workers, about the importance of making sure that people get to the proper place for their health care or their medical care before getting to expensive hospitals or expensive emergency room visits, those sorts of things. And it kind of occurred to me during that advocacy for community health workers that that same sort of logic can and I think should be applied to expanding Medicaid. The same way that we're really concerned about trying to make sure that our state dollars work the most for taxpayers and that we ultimately get the most bang for our buck when we invest. Medicaid expansion is a perfect example of a way in which we can do that. And so I really did highlight that sort of, those sorts of similarities between my ability to successfully advocate for and argue for the community health worker model and funding the community health worker model, and the sort of disconnect between why, as a state, there doesn't seem to be an interest in prioritizing expanding Medicaid. And so, you know, I just talked about the fiscal impact, and also pointed out the fact that in that $11 billion budget, there's about $34 million that has been appropriated for what's called, or what they're calling, Medicaid transformation. Yeah, we're still trying to figure out exactly what that means too. There's a wonderful 115-page report that was put out by a consulting company that cost taxpayers in Missouri about $2.8 million, that basically said that we need to be moving towards some more of a value-based payment sort of a model, that we need to try to figure out ways in which we can leverage more federal dollars. And I'm like, again, it sounds a lot like we need to expand Medicaid. And so it really, ultimately, I ended my floor speech by ultimately saying, you know, that if the people in that body in which I serve don't want to do what I think is both the right thing to do from a moral perspective, but then also the smart thing to do from a fiscal perspective, I've got a feeling that the people of Missouri are going to do the right thing come 2020, because Medicaid expansion is going to likely be on the ballot. And Missouri are going to ultimately do the right thing. So that's kind of the first thing, and I'm going to try to speed along quickly here, Ed. Just two other things that I really wanted to talk about really quickly. Another thing that happened this week, both in Missouri, but then also it was kind of, the timing was just off by a little bit. On Tuesday, in the Children and Families Committee, which I thought was interesting that bill was referred to Children and Families instead of my Health and Mental Health Policy Committee. But there was a bill that was heard to establish work requirements for Medicaid in Missouri. And it was, you know, pointed out that in, I think, all other states in which Medicaid work requirements have even been provisionally approved, those are all expansion states. So the idea of expanding or establishing Medicaid work requirements in Missouri, where just eligibility for Medicaid is so difficult in the first place, just, I mean, I'd never even imagined that CMS would ever approve it anyway. But luckily, we didn't really have to worry about that, because a federal judge on Thursday, I think, struck down both Kentucky and Arkansas's Medicaid work requirement provisions that the Trump administration had approved. So yeah, I mean, you know, clap for that too. I mean, you know, and the thing is that, and it's something, and I really appreciated the quote from the judge in the opinion, saying that he was kind of taking their guiding principles from Yogi Berra. It's like deja vu all over again. They try try to add work requirements, and I've said this consistently, until the federal law for Medicaid is changed, Medicaid is not going to be able to have work requirements because Medicaid was never about work. Medicaid was never a work program. Medicaid was all about making sure that people had access to health care. That's what the purpose of Medicaid has been and will continue to be until it's changed on a federal level. But it also really occurred to me that this kind of concept of the connection between work and health care is really a uniquely American thing. It really is. You know, in most other places in the world, those two things are not tied together. And so it's you know, it's still kind of, those thoughts are kind of still in the nascent stages for me, but it really occurs to me that that's a real opportunity for us to kind of talk about how that's something that's very unique to the U.S. Similarly, there was another ruling, a court ruling this week where those skinny plans, I don't know what else to call them, but those really, really limited health care plans that don't have all the protections that were established and codified by the Affordable Care Act were also struck down by the court. And these are plans for small businesses. You know, but it's like, you know, these sorts of attempts to kind of chip back and chip away at the progress that has been made in healthcare, albeit I can't wait to hear from our panel about the additional progress that can and I think should be made. But these attempts to kind of roll back some of that progress are really meeting a lot of roadblocks and really meeting a lot of obstacles. And so I guess in his own very unique way, Donald Trump just said, well, we're just going to get rid of everything and start over. And y'all figure out how we're supposed to start over. I think the last I heard was kind of in terms of the details of his plan. I gotta make sure I'm quoting this right. We absolutely will have pre-existing conditions. And so outside of that, I don't really know. But the thing that it's so funny. So I mean, I guess it's not funny, but it's like, you know, I mean. The Affordable Care Act, right, was based on Romney Care, which is an incredibly technocratic sort of a thing that was, you know, I've read the laws, you know, 1,000 pages, you know, I can't remember I stopped counting the number of pages of rules and regs that came out in addition to it, like 3,000. I mean, it's incredibly complicated, and you don't just wake up one day and say, we are absolutely going to have pre-existing conditions. Like, there has to be real thought that goes into it. So I am really, really thrilled to be here today to hear from this panel and these experts here about what their thoughts are about what and how we can move forward. So with that, I will turn it over to Ed.
I forgot to mention that you need to use the bathroom loudly. So, just look up there. Okay. Slim reminded me of a few minor details I forgot. If you need to use the bathroom, if you just go through that back door over there and turn right, you'll find the restrooms. Secondly, the co-sponsors of this event are Physicians for a National Health Program, Missouri Healthcare for All, and Missourians for a Single Payer. And finally, on the back, we have what we stand for, a flyer with regard to Momentum. Feel free to take it and pass it along to your friends. So with that, Ed, take it away.
This is great. I'm so glad you all are here. If you're wondering, the slides are available, so just let us know if you want those. So we have a lot to talk about. We don't have a whole lot of time, so we'll get right to this. We're here today because we're having a familial disagreement about where to go. About the strategy. I think in general, you wouldn't be in this room if you didn't think people should really have the ability to get health care when they need it. But we've discovered that within our group in Momentum, we disagree about exactly what that means and how to get there. And so we've been having this discussion a few times on our own. We thought, let's have a broader discussion. And then, wow, this discussion has become sort of the national discussion about how do we go forward. So, woo, you know, good job on Dan LaHocking part and the others for kind of pushing us to get together. So let me maybe tell you what I'm planning on doing for the next 25 minutes. I'm Ed Weisbart. I'm a family physician I practiced for 20 years in Chicago. I came here to work at Express Scripts for 8 years when I was chief medical officer. Retired from that, and now I volunteer at Washington University, seeing patients every week, more or less, and put together the Missouri chapter of Physicians for a National Health Program. We're a nonprofit, nonpartisan, and all that sort of stuff. So I'm planning on explaining what Medicare for All is, in our minds, as PNHP, Physicians for National Health Program. Do that very briefly. We'll talk a bit about the economics of it, but we'll spend more of our time talking about the politics of it, why the politics are the way they are, what you're reading about in terms of surveys and such, and a bit about what isn't Medicare for All in my mind. And then we'll turn it over to our other three panelists who will further enhance that. So that's the run of show. But if I could start, does anybody recognize this guy? No, nobody? So way back in time, he actually had a president that was, okay, so remember when he said this?
Yes.
So raise your hand if you have health care today. Okay, now if it's Medicare, put your hand down. Okay, so if you have health care other than Medicare. So keep your hand up if this private insurance that you have is the same private insurance that you had 5 years ago. Yeah, now how about 10 years ago? Okay, so a few. But that's the point I think that I wanted to make. I myself in the last 7 years have had, I think, 5 or 6 different insurances, health insurance. I have Medicare today, I've had Coventry, I've had Blue Cross Anthem, I can't even keep track of them. So we're constantly going through these changes, and so people are a bit afraid about making another change because we know how painful that is. This would be the last one of those changes. This really would be, Medicare for All would be the last time we'd have to do that. So that's sort of a relief. So anyway, we're all going through this all the time, and that was a little bit not quite the way it is. So here's an interesting, I have 2 quotes for you. I want to just read this one to you. What's the lesson of the 20th century? Social Security, GI Bill, Medicare, you got it if you turned a certain age, or if you served in an explicit way. You just got it. That was kind of the whole conversation. The history of the 20th century, in terms of significant social policy, is that bigger, in terms of getting adopted and getting enthusiasm, getting public support, bigger works better. Years after the Affordable Care Act was passed, I'll bet no one in this room could really describe all of the subtleties of what that law means. Still. So it's very hard to rally behind big, complicated things like that. And we're talking about something actually relatively straightforward. So let me explain what this, in my mind, means to you. Single-payer Medicare for all. And we'll do this very briefly, but it means 2 things. Improve Medicare, because Medicare is imperfect today, and expand it. So improve it, get rid of the financial barriers. As most of you know, Medicare comes with pretty massive copays and deductibles, and those are barriers to care, which people buy solutions for, but we think nobody should have financial barriers to care. So get rid of the copays and deductibles, and then fix the benefit design. Medicare doesn't cover some things it should. So if you're a senior on Medicare today, you may or may not have bought private dental insurance. You may or may not have bought eyeglass insurance. You may have trouble purchasing hearing aids. There are things that most Americans think Medicare should cover. I think that everybody in the country should have access to. There are things. There's about 15 or 20 of these things that we need to improve about Medicare in terms of benefits and getting rid of the copays and deductibles. And there's obviously other things to improve about Medicare, but those are the 2 main things in my mind. And then give it to everybody, give it to everybody in Congress, give it to President Pelosi, give it to everybody. Sorry. Give it to everybody, and that's the only way, really, to get rid of all the overhead that we're carrying every day. The private insurance industry, as you know, has a 15 to 20% overhead in terms of profits and administrative salaries and burdens. 15 to 20%, not counting what the rest of us pay to our doctors to take care of private insurance. 15 to 20% overhead within the insurance industry compared to Medicare with a 2% overhead, 2.2% overhead. According to Medicare. So the best way to get from 18% overhead to 2% overhead is, of course, to go to the one that is 2% overhead. It also is the best way, not the only way, but it's the best way to be able to get the entire country behind getting negotiated prices for drugs. Every other solution is sort of partial. This is the best way to get all of us able to power for that. And it creates a larger risk pool. So there are 29 studies that have demonstrated that we can afford this. 29. There are 2 that don't say that, but there are 29 that say we can afford this, and I want to walk you through one. So of course, expanding healthcare to everybody in the country would have costs, and then everybody would start doing things. So our costs would go up by this study by 12%. They would go to the, people would go to the doctor more. I say that's a good thing, but I have some vested interest in that. But they'd go to the dentist more. I have no interest in that. They would go to the dentist more. They'd get glasses. They'd get the things that we think Americans should go get. There's a cost to that, and that would probably by itself increase the cost by about 12%. But then there's savings, right? The whole system would spend a lot less on administration. We'd be able to negotiate the drug prices. This number is actually bigger than 6%. It's a 40% discount on the 15% that we spend on drugs. So overall, healthcare costs would drop by 6%. Uniform prices so that we don't have one hospital charging 10 times as much for the same procedure for one patient as for another patient. And of course, some more work on fraud and abuse. So there would be dramatic savings that would at least match, and most studies outweigh the benefits or the new costs. And what are these new costs? So we'd go from $3.2 trillion last year, increase it by 12%, we'd have gone to $3.6 trillion, and then reduce it by the savings. So the program, by this estimate, would cost a little bit under $3 trillion. People immediately reach for their back pocket and their wallet, and they say, keep your hands out of there, doc. You know. So how do we come up with $2.93 trillion? One model, you don't have to go crazy on taxes, actually. One possible model would be to do this. Continue what we spend today on public programs, have businesses continue to pay for what they're paying for healthcare today, but less. They could get a discount on what they're paying today. You could have a sales tax on non-necessities. I'm not advocating for this. This is one way you could do it. You could have a small tax, less than 1% tax on net worth over $1 million. Again, I'm not advocating for this. I'm just showing a tax on long-term gains. So I'm just showing that this combination of not outrageously crazy 90% tax rates, this combination of taxes would wind up more than funding what we would need. So again, I'm not advocating for this tax proposal, but my point is, yeah, of course we can afford to do this. And indeed, every other country affords to do this, right? Here's what all these other countries spend per person per year on healthcare, total, and that's with 100% of their population covered. Here's what we spend on tax dollars, almost as much more than most other countries, and of course these tax dollars are not for universal healthcare. And then if you add in the rest of what we spend, it's that much. So we're spending roughly double any other country. Okay, so that's kind of straightforward. Let me ask you a question. Raise your hand if you want apple pie. Right now, you want apple pie? I'll even give an ice cream too. Okay, so we give apple pie polls pretty positively. So what if I told you that it was tasty, really tasty apple pie? What if I told you it was homemade, really tasty? You'd probably want it. What if I told you that this apple pie is going to cause obesity and diabetes? Raise your hand if you want that. Still want it. Raise your hand if I told you that it caused heart attacks. It had poison in it. You want it? Raise your hand. Or if I told you it was $5,000 a slice. Raise your hand if you want that apple pie. My point is, surveys, it's really important what you ask in a survey. So let me show you a survey. How popular is Medicare for all? Because this is one of the hot topics in the news right now. Well, people don't really want it when they know what it is. Well, let's see, what is it? Guaranteed health insurance as a right. Yeah, strong majority of people say I want Medicare for all because it means guaranteed health insurance as a right. Still a strong majority if they're told it's going to eliminate premiums and reduce out-of-pocket costs. Yeah, that sounds great. Okay, cool. Well, that's as far as the surveys went a year or two ago. It's just that far because we didn't yet have all of the army of resistance that we have now from the insurance industry, right? We knew this was going to happen. They didn't take us seriously 2 or 3 years ago, forever, and so they weren't like really fighting us. Now they are because they realize that the American people are starting to demand this. And so now we're seeing different kinds of questions being asked by reputable sources. So here's one. What if you were told that Medicare for all would eliminate private insurance companies? Well, not so good. No. But that's the question. If it eliminates private insurance companies, it's only half of the equation. That's not saying, what if we told you no more private insurance because nobody would need it because everybody would be covered under a robust, great program? They would answer differently. So if you tell people, if you do this survey, You still want it if you knew it gets rid of private insurance companies. Of course nobody wants it at that point because they're not getting the context. But that's being surveyed. You see it all over the Fox News that I watch in the gym. Nobody wants it because it's going to get, well, that's because of the way the question was asked. What if you're told it's going to raise taxes for most Americans? Well, of course it's going to raise taxes. It's a publicly funded program. It's not a secret. But it'll raise taxes less than you'll save by not paying a premium, by not paying co-pays, by not paying deductibles. And that's not being controverted. Everybody kind of agrees that that's the case, almost everybody. The Koch brothers agreed that that's the case, actually, in other studies. So if you're asked this question, no, I don't want that. You know, really, I got these premiums and I got to pay taxes? No. So it's the question that's being tricky. Or what if you're being told Medicare for All would threaten the Medicare program? It would, because it would add stuff to it. It would give you Medicare plus more things. But you're being told it's going to change Medicare. So my point is, these surveys that say there's low popularity once they know what it is are very misleading, and they're not really, oh, I have one more. Yeah, that it's going to delay medical tests. Well, there's really no basis for that statement. So, of course, the survey questions matter. And it turns out politicians are kind of it takes the unique kind of logic that only a politician or legislator, other than Cora Faith Walker, could come up with, to take a program that has this enormous popularity that people are literally demanding, that was the driving force of the last election, and to say, we can't do this, it's too radical. Most Americans won't take it. No, they will. And here's a data point on that. On this chart, this is a survey of what politicians think versus what their electorate thinks. And the green line is if the politicians actually knew what their electorate thinks. Here's politicians estimating, so in this district, wherever that dot is, these politicians are saying that 60% of their electorate would want Medicare for all, right? Because they're 60% and they're 60%. Here's what liberal politicians underestimate the popularity of the program in their own district, and conservative politicians even more underestimate it. So it's up to us to do things like what Momentum is doing, what all our co-sponsoring groups is doing, get people to understand the facts of the situation. So single-payer Medicare for All is not the only public health option that we could take. I just submit that it's our best one of the many choices. One that I think is not one of our best choices is the public option. So raise your hand if you understand what the public option is. Medicare buy-in, very similar things. Okay. So let me walk you through what this is, because frankly, I think this is the concept that's beginning to take over one of the Democratic Party's mindset. This is what they're actually starting to migrate towards. And many within the Democratic Party who claim to be running on Medicare for All are really running on the public option. So you need to understand what it is so that you can form your own opinion on whether it's a good or bad idea. It's very tempting. It's a very seductive, tempting idea. And frankly, 3 years ago, had you asked me, I would have said, this is a good way forward. I no longer think that. But let me walk you through this. The basic idea is take Medicare, right, and price it. So if somebody who's 64 years old or 50 years old, or in some cases 30 years old, said, you know, I don't want Cigna, I want Medicare, can't I just buy it? So that's the concept. Put a price tag on it. You know, let the government figure out, here's what you should pay if you want to buy into Medicare, your age or what have you, and put it on the market. Let people buy it. You know, it's a very tempting idea. It's a buy-in. It's an option to have available, and there's 10 different flavors of this right now. Some of the plans would say, some of the proposals would say, and let employers stop offering Cigna if they don't want to offer Cigna. Let an employer offer Medicare if they would rather do that and price it for that. So there's a lot of variations to this, but that's the basic concept. It's very appealing to those who are inclined towards a free market. And I got to be honest with you, I'm inclined towards a free market. I'm a capitalist. We had a retail store. You know, but I think so this has an attraction to it in many ways. Put Medicare on the market. If it's such a great idea, put it nose to nose with its appropriate price against Blue Cross and the others. And if it's really a great value proposition, people will buy it. And if it's not, it'll go away and we can stop talking about it. Very appealing. Very appealing. And the argument is, you know, don't tell the insurance companies, but this is going to get us to Medicare for all. They won't figure it out. So it's not as heavy of a political lift. That's kind of the concept. This is a less intrusive, less abrupt lift. It'll be easier to do it with less opposition. So that's sort of the argument for it. Like I said, not too long ago, I was advocating for it as a way forward. But there's other things to think about. The first is, it doesn't pay for itself. It comes out of premium dollars you gotta pay for. It misses all of those savings I was describing, going from the 18% overhead to the 2% overhead. Unless you're in this program, it's not gonna happen. Plus, this program would have to advertise. It would have to do a lot of the things that take you above the 2% overhead. So it misses most of the savings. It doesn't necessarily let you negotiate the prices of drugs for the whole country. That's kind of a separate topic, worth having perhaps. It has minimal impact on the uninsured. The estimates are that a small minority of the 28 million uninsured today would actually opt into it. Why? Because they've decided that they can't see the value. They don't have insurance today, typically not because there isn't one on the market, it's because they've decided that it's too expensive and that they don't think that the value is there, so they're choosing not to buy it. Okay, so you could say, well, what we're going to do is we'll put it on the market, and if you're of such and such income level, we'll give you a premium subsidy. Okay, that'll help, I guess. But then that means it comes out of tax dollars, and how does this get tax dollars? Where's the savings? So this will just increase the budget. So it's an expensive way to have any impact on the uninsured. It'll have a high risk pool, because again, the sickest will be the ones who would go into it, so it will become increasingly expensive. It fundamentally doesn't do anything for those who are underinsured. It doesn't improve the benefit design. We still have medical causes, healthcare is the biggest cause of bankruptcy in the United States, so it doesn't help with that, and it doesn't fundamentally improve Medicare. There are versions of this that say, well, and let's do these 16 other things, but a public option doesn't fundamentally necessarily include dentistry and eyeglasses and all that stuff. And my submission to you is, we will spend 4 to 5 years fighting for the public option, and then once it's done, we'll go, please don't talk about healthcare again for a while. So we'll spend the next 4 to 5 years waiting to see if it worked. So we'll spend 8, 10 years fighting for this, which we'll do a little bit. I see patients all the time who are literally dying because they can't get in to see a doctor regularly. They can't get the surgery they need. I can't bear the thought of another 10-year delay on that. Not when we have such popularity for the movement. So my last quote for you. This one was from Bill de Blasio, Mayor of New York. Social Security. Look at the buy-in of Social Security. Look at the buy-in Social Security has. It's got bipartisan. It's got people of every region, every background. Almost everybody in the country believes in Social Security. Everybody. Obamacare, people don't really know what it is. So when it's universal, like Social Security, it takes away all of the mystery. It's a simple thing to understand. When you tell people it's there for you, no matter what, that's not only morally right, it's a winning hand politically. It's a winning hand. So if you like this kind of stuff, be sure you sign up for things, or you can go to showmemedicareforall.org. That's MHP. And great. And we'll do questions during the panel session. Let me introduce Ken to you.
Well, thank you, Ed. I'm going to come in with a somewhat different perspective. I agree, by the way, with a lot of the comments that Ed made. I agree.
If you want, you can use the microphone if you want.
Please.
Can you hear me?
Yeah.
I usually like to walk around. But I think at a fundamental level, there's a real challenge with Medicare for all. And I'll get into that in a bit. I'll talk about these things, some of which will duplicate what Ed had to say, and I'll probably skip over those. But I want to begin by giving you a little bit of my own background, since I know I'm going to be giving you a perspective that probably most of you are coming into this room not agreeing with. I suspect I have a more left-wing background than anyone in this room. I grew up in New York City in a place where I never knew a Republican. I thought they were aliens with horns and flames flowing out of their nostrils. My parents came of age during the Depression, and as they saw the capitalist system coming to pieces, they looked elsewhere for solutions. If anything, they thought FDR was too far to the right. I spent my 8 years, from about age 7 to 15, at a summer camp in upstate New York, where We Shall Overcome was the camp song, where Pete Seeger was an annual visitor, and where we spent more time remembering Hiroshima Day on August 6th than we did July 4th. You won't be surprised coming out of that background that I support most of the kinds of issues that progressives support. We should have a $15 minimum wage. We should do all those good things. We should have universal child care, etc. I also strongly support the notion that health care is a fundamental human right, and the dysfunction of our healthcare system is legendary and totally inexcusable. But I'm also have spent my entire adult life as an academic scientist. I'm the one non-physician on the panel. I'm a mathematician by training and a professor at Washington University School of Medicine. And the one thing I have learned as an academic scientist is that skepticism must be the watchword of every search for truth, no matter whether it's a scientific search or a search for truth in this kind of domain. And I'm afraid that when I look at Medicare for All as the solution to our healthcare problems, what I find is that it falls apart almost everywhere, as wonderful as the goals are. And it does have wonderful goals. These are the kinds of things that it can and would accomplish if it ever became law. But, and this is the central point of what I want to convey, you do not need Medicare for all to have affordable universal coverage. There are many approaches. You look all around the world. There is not a single country, a peer country, that doesn't have private insurance. Cuba doesn't have private insurance. There are a few other smaller countries, poorer countries, that don't. Every single Western European country has private insurance. Every single Western European country has out-of-pocket expenses. They are controlled, they are carefully regulated, the insurance companies are carefully regulated, and we'll see some of that as we go along. But our task is to be skeptical about anything. I don't want you to agree with me because of my incredible good looks. I don't want you to agree with me because you came in here agreeing with me and say, wow, he's reinforcing what I had to think. I want you to agree with me because you've listened to what I had to say. You've listened to what Ed has had to say and other panelists. And you've challenged them, you've challenged me in your own mind, and you came out and said, you know, it makes sense. And that's the only reason you should agree with Ed, because you've challenged what he has to say and have concluded that it makes sense. Just to quickly summarize, the Sanders Medicare for All plan basically says this: comprehensive Medicare, comprehensive single-payer universal coverage, no premiums, no co-pays, no out-of-pocket expenses, no private insurance financed entirely by federal taxes. There's not much to disagree with there. It would be wonderful if we had that. There's a bill in the House by, I've never quite known how to pronounce her name, a congresswoman from Washington State, Jayapal. Is that right? Jayapal. It's very similar. It's actually a little bit more comprehensive than the Sanders plan because of the way it handles long-term care. It's implemented more quickly, 2 years instead of 4 years. It negotiates drug prices and so forth in a way that really is a very positive addition to the debate. because we do need to do that. We do need to, as every other country in the world does, have a mechanism for deciding what drugs should be covered and what shouldn't. But again, it's what the rest of the world already does. You do not have to have single payer. Some of the countries that do have, quote, single payer, because nobody really has single payer. They've come close. Cuba does have single payer. We can do these things through many, many different mechanisms. Some stipulations. Ed is absolutely right. We can afford Medicare for all. No question. This is a rich country. We can afford it. It will provide affordable health care to millions who are currently denied access. No question. I put my first, almost certainly, caveat here, although I agree with Ed on this one as well. Medicare for all will be economically more efficient than the current system. What does that translate into? That translates into the notion that the average person, and I put in great big quotes, the average person, because I'm going to point out to you tens of millions who go in the wrong direction. The average person will indeed save money under Medicare for all. I think that's right. There are a few studies that say no, but the overwhelming majority say yes, it is correct, and I agree with that. But when you're counting, I mean, saving money means the amount you pay in taxes will be less than the amount that you currently pay in healthcare expenses. If your current total is greater than your Medicare for all induced tax increase, then you're home free. But if your current medical costs are less than the Medicare for all induced tax increases, you're going to lose money. I will point out to you that there are tens of millions of people in this country who will unfortunately be in the category at the bottom of this slide. A key point about cost savings. There are non-single payer universal care systems all over the world that have lower costs than the US. It's hard to have higher costs than we do. It's hard to be less efficient than we are. But nobody, we're unique in that, nobody has succeeded in out inefficiency. That's a new word, but you do not need Medicare for all. There are models all over the world that negotiate drug price and device prices, that save money with hospital-specific lump sum payments, that have a federal agency decide whether you should or shouldn't cover a drug or shouldn't pay for a device, etc. It's done everywhere. It's done in England and Canada, where they have single-payer systems. It's done in Germany and the Netherlands and Switzerland, where they don't have single-payer systems. What is the effect of the Sanders plan on taxes? Well, I'm going to show you a whole range of data here to give you an idea that, frankly, I don't know. I don't know how big it is. Here are two of the biggest estimates. One comes from the Urban Institute, a very liberal group. A study was done of the $79,000 worth of donations coming out of them. Not a single dime went to a Republican, people who worked there. The other comes from the Mercatus Center. I think Ed referred to that before. That's a Koch brothers funded study, a Koch brothers funded center at George Mason University. Both of them came out with roughly the same figure of $32 trillion. That's $10,000 in taxes. That's $10,000 per person per year over a 10-year period, assuming 320 million people in the country. Total tax revenue in the United States is currently $3.4 trillion a year. So this would come close to doubling the total tax revenue. There was a study out of Emory University that's less. The Sanders initial estimate was about 16 trillion when he came out with it. And this is the example that Ed was using before of, out of the University of Massachusetts, a liberal organization that came out with a figure of about 10.5 trillion, and Ed delineated some of the savings there. I am not a healthcare economist. I can't say to you with confidence that it's really 32 trillion or it's really 10 trillion. What I can do is provide some off-the-cuff data which is really inadequate. And it leaves me with a lot of range of uncertainty as to what this figure really should be. But currently we spend nearly $2 trillion a year in private health care costs. It's about 1.8 trillion. By the time any new bill is in effect, it's going to be over 2 trillion a year. There are 29 million, roughly 28 million is what I'd use, uninsured people. They have to be covered and paid for through the new taxes. There are going to be increasing costs due to an aging population, increasing costs because, unlike today, everything is covered. I don't want to sound like somebody who is saying, well, we shouldn't cover everything. Well, but we just talked about which drugs we're not going to cover. That's what they do all over the world. That's, I think Ed endorsed that. There are going to be things that aren't covered. Healthcare is so ungodly expensive these days. We have to decide, where do we go? For many years, to take one example, most European countries did not do heart transplants. They are extraordinarily expensive. As time went on, as the efficacy of those transplants was proven, that is when they started spending the money and doing it. But healthcare is astonishingly expensive. We have to be in a position of making decisions. I'm not a healthcare economist. There's a lot of savings I'm leaving out of this equation, and Ed's probably ready to jump up and point that out. There are. Do they make up this 2 trillion plus these costs, which I'm not going to attempt to put a number on, plus this? This does get you up to something approaching the 32 trillion, but there's savings. How much of it is? I'm going to leave that to you guys to figure out. I don't know the answer. I don't think anybody knows the answer. Those of you who trust your neighborhood health economist to predict next year's economy, more power to them. These are very, very imprecise kinds of calculations. To me, the moral is the Sanders $16 trillion figure. I just don't see how that's feasible. It seems to me to be a gross understatement, and we're moving up towards the 32 trillion. I don't know whether we get there. I don't know where we end up. But the 16 and the $10.5 trillion figure are just not there, and that has an awful lot to do with our taxes. So what is the effect of the Sanders plan on taxes? Just to put this in perspective. Elizabeth Warren's proposal for wealth tax, 2.7 trillion. Ocasio-Cortez proposal for a 70% tax rate, 700 billion. Doesn't come close. It's not even in the same ballpark as what's needed for Medicaid for all. The Sanders plan includes a 2.2% individual tax rate and a bunch of other things. 2.2% for everybody. Well, in Germany, where they, by the way, do not have universal health care, well, excuse me, where they do not have a single-payer system, they do have universal health care. These are the tax rates that people pay across the board. Most countries don't have dedicated taxes. In Denmark, where they sort of have a universal health care system, but there's a lot of local payments that go into it, so it's unclear. At 8% national tax, a lot of local taxes. In Vermont, where there was a proposal by a strongly pro-single-payer governor to institute such taxes there, it died in the water when the economists that they hired projected an 11.5% tax rate on business and up to 9.5% personal taxes. I don't see how anything close to 2.2% is feasible. No matter how much you want to soak the rich, I am in favor of soaking the rich. But when we're talking about such massive costs, it's hard to do. This is a complicated slide. And it comes from the organization from Economic Cooperation and Development, an organization of, I think it's now 36, mostly developed countries. There are a few in Eastern Europe. There's Chile. There's a few countries that are not quite so wealthy. This is a graph with 11 of those countries. It's older data, my apologies. But this 7,500 per person in the US, which is the outlier, is now about 10,500 per person. But take a look at this. Every single country here is broken down by out-of-pocket expenses, private expenses, which means basically insurance payments, and public spending. Every single country here has out-of-pocket expenses. Every single country here has insurance expenses. Every country. Sanders doesn't. They all have private insurance companies. Sanders doesn't. No peer, I put the dates on here for the single-payer countries, or close to single-payer. And I put it in quotes mostly because there are no fully single-payer countries in the way that these Medicare for All proposals would be. They don't exist, period, except in some smaller, poorer countries like Cuba. Notice the dates in which they were instituted. Almost always decades and decades ago, before healthcare became so expensive. When healthcare was 2 and 3 and 5% of the total economy. What we are talking about here is re-engineering 18% of our economy. There is no historical precedent for that. You'll notice also the single-payer countries, some of them are equivocal. I mentioned Denmark before. I haven't listed it as single-payer here. It could be listed as single-payer. The cost is maybe a little bit cheaper. It is indeed the case that a single-payer system is simpler and will have lower costs, lower administrative costs than other models. But that's a small difference. It's not a small difference compared to what we have today with our insane system. But it is indeed a small difference compared to Germany or France or Norway is single-payer, or Switzerland, which is not single-payer. The costs are roughly the same. It may be that the single